Good afternoon, everyone. Thank you for coming to this session. I'm Peter Quiros I'm an associate professor at UCLA, and I'll be moderating our session today on how to communicate with patients that are different than you. We thought this session was going to be very important because as our communities become more diverse, our practice has become more diverse. Anywhere from the largest city to the smallest town, you're going to encounter situations that you may not be used to handling or you may not be handling appropriately. And we thought this was a way to help you communicate better with your patients and become a better IMD. Our first speaker is going to speak to us about speaking to the elderly with early dementia. This is Dr. Hilary Beaver, who is the Blanton Eye Institute, who is Associate Professor of Ophthalmology at the Blanton Eye Institute at Houston Methodist Hospital, as well as the Cornell Wheel Medical School. And she is also Adjunct Associate Professor at University of Texas Medical Branch, Galveston. Again, she will speak to us about the elderly patients with early dementia. Thank you, Dr. Beaver.
Thank you. So this is a ever-increasing group of patients, so it's a good one to get comfortable learning how to sit down and talk with. I have no financial disclosures of interest, and there's no off-label usage. My objectives are, at the end of this, that you should be able to differentiate between mild cognitive impairment and dementia, and to be able to recognize the components of early cognitive loss and recognize how it affects communication. It affects both how the patient receives your communication and how they're able to formulate a response to you and deliver communication back. You will be exercising your communication competency. You already know what to say. You do that with every other patient. We just need, in this group of people, to know how to say it and who else to include in the conversation. So mild cognitive impairment is early cognitive loss. It involves short-term memory and executive function. It's a loss that's greater than expected by age, and it's noticeable, but mostly it's noticeable to people who know that patient. It is measurable. Neurologists will do special tests looking for this and be able to quantify, and they like to see these patients back on an every 6 to 12 months basis. These patients have an increased dementia risk. They have a 10 to 15% per year conversion to dementia as compared to 1 to 3% per year for the average 65 and older population. This means that in 7 years, 80% of these people will have dementia. There are risk factors: age, vasculopathic risk factors, and a family history of dementia. And in this population, it's about 15 to 20% of those who are age 65 and older. This contrasts with dementia, which has cognitive loss, both memory and thinking skills, which affects daily function, so your activities of daily living. It's actually a group of diseases. It's not just one disease. And of course, number one in that group is Alzheimer's, which accounts for about 60 to 80% of dementia. Number two in this group would be Parkinson's. It involves 5 core mental functions, and for dementia, you need to have significant impairment in 2 of these. And really, we use all 5 of these in an eye exam, sitting down, examining the patient, talking to them, having them receive our message, and then go and do what it is we're recommending, which is memory, communication and language, the ability to focus and pay attention, reasoning and judgment, and visual perception. These patients have insight, and they're scared. They know they have memory difficulty. They start bringing people with them, families and friends, and have them write down your instructions to review later. Often they'll report that they have self-limited activities, such as driving. And really what their fear is a fear of Alzheimer's, because they have seen other family members and friends who have gone through Alzheimer's disease. So one of the first things you want to do is to identify a care partner. If they seem to be having difficulty, you can broach this topic with them, and they'll understand, and have them bring a family or friend with them to help them, because they can't be paying attention and writing things down themselves at the same time. You want to get a HIPAA release early on for this family or friend, because they will call you back and ask you more questions, and if they're not on your list of releases, you have to actually ask to speak to the patient. You want to triangulate your discussion. Don't just talk to the caregiver. You want to be talking to the patient, but you want to include the caregiver. So if you're person B and the patient is person A, make the caregiver person C. So you're sitting in a triangular pattern looking back and forth between them. That will also cause them to look back and forth between each other, and all of you are getting involved in the discussion. It reinforces your instructions to both of them so that they can both remember. It also helps the patient maintain respect. It makes them feel valued, and it decreases their sense of isolation, which comes along with having cognitive impairment. This patient can then assist the patient with tasks, follow-up care activities, and coming back for their next appointment. Be compassionate with these people. They are frustrated just as much as you are frustrated. They are having to live with their lack of communication with others. This is part of the disease process. They have trouble processing what you're telling them. It takes them longer to receive it and to think about it, and then to formulate their own response. So you have to take time and let them formulate their response and just wait. They're afraid, and that's also affecting their ability to interact with you at the moment. They live in a state of mild confusion, anxiety, and uncertainty, and being in your office is making that worse. And they know many of them are going to worsen, and they're afraid of that. They will have good days and bad days, and it's okay to acknowledge that with them. And if they respond that they have certain times of days that are better, tell your front desk to schedule accordingly to help them out. Be respectful of them. They actually know what they want to say. They're just having trouble formulating a response. So slow down and wait for them to respond. Speak clearly, and remember, in these cases, it's actually better to have multiple short, small visits to review one thing at a time, which is really all that they can handle, and avoid one great big, long, complex, multitasking visit. Use your nonverbal cues. They're using theirs. They can read you. You should sit down and read them. Look at their facial expression, their body posture, and you want to make sure that you yourself are internally consistent, so that your body language and your facial expression and your delivery of what you're saying doesn't confuse them. You want to use slow, gentle movements, smile at the patient, and sit down looking face to face and eye to eye with them. Do not stand above the patient looking down, because that's perceived as being threatening, and that may accelerate the patient into bad behaviors that they can't control. You want to respect their personal space. Remember that one of our major nonverbal cues is pictures, and if you use a picture, they may be able to take it home. You could also write down and have take-home instructions. Human touch can be reassuring as well. Remember to be an active listener. So if they say something and you're confused, ask them to repeat themselves. If you're still confused, you want to repeat back to them what they said so that they can clarify. And when you're asking them questions, make them simple questions, yes/no questions. Do not ask them multiple choice, branching questions, or open-ended questions, because they'll get lost in the response. Minimize distractions that are going on while you're having your meeting. Have an enclosed space. The eye clinic is actually very good for this. Shut the door, limit external stimuli, try not to have the technicians interrupt you, because this will mentally tax the patient. And ask them when they're giving themselves medication, doing their self-care, that they do the same thing. Have them close the curtains, turn off the television, turn off music, because it will distract them and they may not complete the task that they're doing. Position yourself so that you can get the patient's full attention. So again, sit down, be face-to-face. Don't start until they're looking at you. Look eye to eye. Turn the lights on. We tend to keep the lights down in the eye clinic, but you want to have good lighting, because a lot of these patients have hearing loss to some degree as well, and they may be spending some time lip reading. So don't do this with your back to the patient. Announce what you're going to do before you do it so you don't startle them. Try to look open and relaxed. And if you're having a bad day or a stressful clinic and you see a name that you know is a patient that has this problem, you need to de-stress yourself before you enter that room, because they can pick up on those nonverbal cues. Use proper nouns. Go in and greet them by their name and introduce yourself by your own name and tell them who you are in relation to them and what it is you're about to do. Don't use pronouns when referring to other people, such as those who are going to be helping to take care of them, because remember that dementia creates the penultimate indefinite antecedent. They're not going to be able to follow your train of thought and know who you're talking about. Recognize that this kind of communication is a learned skill, and you're going to get better at doing it the more you do it. If you sit down and they look confused when you try to speak with them, repeat yourself. Say the same thing and give them time. If they still seem confused, then rephrase yourself. And you can read their body language again. looking at their nonverbal cues to be able to gauge their understanding. And sometimes they'll be able to express themselves better with nonverbal cues than with verbal speech. And it's okay to suggest words when they're trying to speak, but let them try first. When you give instructions, make them concise. Break down a complex task into a series of simple steps. It helps to write it down and number it. And if you feel like you're time pressured, just tell them what it is you need to say, but that you're going to send them a letter afterwards, which will have this summarized. And you can turn parts of that letter into a handout because you're going to be running into similar problems with other patients. It helps to use your sense of humor and laugh with them. This is just the penultimate nonverbal cue of saying, I understand you, I like you, I acknowledge you, and it will put them at ease so that they can interact with you. Finally, just take the time to communicate. Research has proven benefits to communication. They're more likely to adhere to their treatment, they have better outcomes and greater satisfaction and less lawsuits, and it helps the patient preserve their individuality and their personal identity. So, in summary, you should now understand what the difference is between mild cognitive impairment and dementia, and be able to recognize the components of early cognitive loss, recognize how it affects their communication with you, and you should be able to tailor your interaction with the patient, not just what to say, but how to say it and who else to include in the conversation. There's many resources that are available, both through Alzheimer's associations, Caregivers Alliance, the American Geriatric Society, and the federal government, and I thank you for your time and attention.
Our next presenter is from Bascom Palmer Eye Institute and is associate professor at the Miller School of Medicine at the University of Miami. And this is Dr. Raquel Goldhardt, and she is no stranger to communicating with patients that speak a different language, as she was born in Brazil. And so she has personal, and after completing residency in Brazil, repeated her residency in the United States at Tulane, and then went on to do a retina fellowship at Bascom Palmer and a uveitis fellowship at UCLA. So she has firsthand knowledge of how difficult it can be to communicate with patients who speak a different first language than you. And so she's going to speak about the language barrier in communicating with patients that speak a different language. Thank you, Dr. Goldhardt.
Thank you. Thank you so much for the invitation as well. So he started with a nice introduction, and I would say, well, maybe I could start this talk and say, get a translator, right? And we are done with it. But just having a translator would not include. And that's what we want to do. So my question is, how are you doing? And like in your practice, like regarding the way you communicate with your patient. When communicating with them, are you making sure that he or she feel comfortable? The most important part of that interaction. And are you providing to your patient that sense of belonging and making him or her feel valued? Inclusion is what really matters, not just get a translator. So nowhere is diversity and inclusion more important than in healthcare. I think they are critical, not just to provide a high quality of care, but also education. And, but we have to be able to connect and communicate with the patients. So if we speak different languages, how can we achieve that goal? In 2014, the CMS Office of Minority Health has published an issue brief stating that overall 8% of 52 million Medicare beneficiaries across the country have limited English proficiency. And it was most prevalent in Asian Hispanic patients. Now, overwhelmingly, we know the most commonly spoken language outside English still is Spanish. But the number of non-native English speakers in the US now includes over 60 million people. It nearly tripled the number from just 3 decades ago. With nearly 1 in 5 Americans speaking another language at home, of course, medical professionals, not just physicians, are bound to come across those patients with whom they're going to have difficulty communicating with. So yes, employing a medical interpreter is vital for those situations, and But like I said, it's not all that matters, and I'm going to talk about that. So one very important point about the patient engagement is a meaningful interaction. 3 strategies to achieve that is give the health data to the patient. Let them look at the numbers, let them look at the results, let them make their interpretation, and then you go over that. And the way you communicate with them. And look back at the patient satisfaction. Because sometimes you think you're communicating well, but they don't think so. So in healthcare, bridging the language barrier is necessary to avoid clinical errors, provide patient-centered care, and comply with legal and regulatory mandates. Communication, it can take multiple forms, but I would talk about the most basic sense. It's just the face-to-face. You have to first listen. Don't interrupt. Sometimes it's difficult, we want to run, but especially with these patients is important. And remember to be empathetic. Be mindful of patients' preferences because they have different cultures and they bring a lot of other ideas that you're maybe not even used to. And look at your patient. You still need to make a personal connection. I know healthcare is like becoming saturated with technology, and many claim that's a good thing. But studies shows that patients respond better to you, to the provider, if you spend less time looking at the screen. So if you think you're frustrated trying to communicate with a non-English speaking patient, just imagine how scared and overwhelmed they must feel. So they're sick, sometimes just vulnerable, and surrounded by all these people jabbering a different language. Provide this environment that welcome people from all languages. It starts long before your interaction with them. It starts with the people on the phone, making appointments, prescription, follow-ups. If they call and they cannot get anything through, they don't know what's going on, they're not going to come back. So there's a few tips here, and one is learn a few polite expressions. You know the 2 languages that are commonly spoken here, so you can learn a few polite expressions. A simple good morning or a thank you in the patient's native language, I think will go a long way towards improving your relationship with them and also building trust so they will come back. Keep it simple. The shorter the explanation, the better. So aim for words and phrases that are simple to understand, easily translated. Long explanations can lead the interpreter to summarize your words in a way that maybe doesn't express fully what you're trying to say. At the same time, try not to patronize the patient, just not to try to decide for them. One good example, just about drops, simple drops. I love Sharpies. And maybe in Spanish you already know how to say a few things in Spanish, but maybe not in Chinese. So Sharpie is excellent. You can mark the bottom, mark the box. You can get a piece of paper. You can even communicate drawing something with your patient, but do the best you can. The tip number 3, look at the interpreter. If you have an interpreter there, it's not just look at the patient, but to the interpreter. It's very important to stay engaged while the interpreter is translating your words. Because if you look through the chart, just try to avoid talking to others in the room, look through the window because it's translated. Just you have to signal your interest by facing the interpreter. Patient will see that. You have to remember those things. Try to do that. Try to make a conscious note of that. And speak in full sentences. Yes, short, but full sentences, because you may think that's helpful to stop mid-sentence, to allow the translator to catch up with what you're saying, but maybe doing that, you're going to put that information out of context and maybe even get an inaccurate oral translation. Now, the federal law requires linguistic services for patients with limited English proficiency. In addition, the healthcare organizations that receive federal funds must provide services in a language that a patient can understand. So if you don't know the language at all, you have to have a reliable source of interpreters. And you have to document that the use of interpreters. So avoid the use of patient family members or friends if you can. And the interpreting encounters, they are going to take longer, but they will save time in the long run. And if you want to be a better doctor, do that. On-site interpreters, yes, are better, but they're costly. You can use a telephone, video conference, And Basque Palm, we have a lot of Spanish speakers in Miami, and they love Google Translate. Be culturally sensitive. Become a culturally competent doctor. I would say, appreciate that. Just don't be appropriate. Appreciate. Look at your patient. Remember all those things that I said and connect with them. You're going to be an even better doctor than you already are. Thank you.
Thank you, Dr. Goldhardt. Our next speaker is Dr. César Briceño, who is an assistant professor of ophthalmology at the University of Pennsylvania. He is an oculoplastics specialist, and he will be speaking to us on speaking with and caring for transgender patients. Dr. Briceño.
Thank you, Dr. Quiroz. Thank you so much for this invitation. And I'd like to say that a lot of my experience with transgender patient populations actually comes from my medical school experience. When I was at Johns Hopkins, I volunteered at the Gay and Lesbian Community Center of Baltimore, where I did HIV testing, and that's probably where I got most of my learning in regards to this very complex and evolving topic. And so I'd like to share with you a lot of themes that have already actually been covered by the prior speakers. And really the crux of the matter is that cultural humility and the ability to listen are probably the two things that you need in order to navigate any difficult patient encounter with someone who's different than yourself. And so I have no financial relationships to disclose. We're going to review some key terms and concepts. We're not going to belabor them because the lexicon is continuously changing and quite complicated. We're going to talk a little bit about some of the healthcare disparities that this specific patient population faces, because that's very relevant to how we deliver care. And we're also going to share a few resources and strategies for how to train yourself to be better at this, because it is very trainable, and you'd be surprised how quickly your own comfort level can improve if you take a few of those steps. So some of the things that you'll see out in social media and in the news and whatever are words like these: someone who's transgender, who's a gender minority, or who identifies as gender queer. The term transsexual is still a medical term that you're going to run into in the literature quite often. Also gender dysphoria as far as descriptions of the condition, and people who are cisgender, who are in fact not trans, but the opposite, whose phenotypic and genotypic and mental gender all coincide with one another. You know these words, you're familiar with them because most of you have trained in medicine. The point is not to go through their definitions, but rather to understand that they actually do mean something a little different to each person that you're going to encounter. And whereas to us, it may be a way to codify and understand from a medical standpoint where our patient is coming from, for them it's really an identity. And I think that that's where we need to be respectful of that. And so oftentimes when there is doubt, or when you perceive someone visually and you want to try to understand where they are in the spectrum, resist that temptation. It's better to ask, and to ask in a humble way, and then actually respect what the patient has told you. It takes all of 10 seconds, and it makes all the difference in terms of that patient being willing to trust you, and then you being able to deliver proper care. So, oh, that was just some more stuff there. Words that are offensive. And so, it may seem a little bit obvious to put these here, but these are words that our patients deal with all the time, not only in healthcare settings, but at the DMV, and at the post office, and at the grocery store, and everywhere that they go. And so this is a population that is constantly under assault, both socially and oftentimes physically. They are more often victims of violent crime and murder, and a lot of that starts with words. And so words like these are things that not only you as a provider need to avoid, but that you need to make sure that your staff, the people who answer the phones, the people who are at the front desk, know to be sensitive and know some trigger words to avoid. These matter. Just like the racial epithets that we know to avoid, these are also things that we have to learn to avoid, because it matters in terms of how we are perceived as professionals. It is okay to be curious, and in fact, it's necessary. You need to ask your patient how they want to be communicated with and how they want to be treated in terms of how you record things in a medical record and how you represent them. However, there are certain ways of questioning that are more helpful than others. And so the tendency, at least in popular culture in recent decades, has been to somehow exoticize people who are trans. And so questions like these can be very provocative and not in the ways that you intend. And so again, a lot of these things come from a good place. You want to understand whether the person has had surgery before. You want to understand whether they're taking hormonal treatments. You want to understand their own perception of their own gender fluidity, if it's applicable. But you have to do that in a way that is humble and that is not judgmental. And so questions like these are off limits. We said that we'd talk a little bit about disparities, and so let's go over that just a bit. Transgender patients are indeed underserved in many respects. There are some unique challenges that come along with transitioning or being gender non-conforming. Many of these patients are uninsured, and a lot of these patients have reported in a national survey that they had to, in fact, teach their medical providers about transgender care. So this is a unique situation. You know, a lot of other patient populations never experience this, but this is a patient population where you may go to a provider who's presumably the expert, who actually doesn't understand your medical condition well enough to be able to put it in the context of their specialty. And this is something we should generally avoid if we can help it, and it's not difficult to do. Family rejection is very prevalent. More than half have been kicked out of their home or no longer communicate with their family. Verbal harassment, or just harassment when presenting an identification where the phenotype doesn't match what the person's seeing in front, for example, at TSA, at the airport. Poverty is a serious issue because employment comes along with all these other types of stigma, and a lot of transgender patients are underemployed or unemployed. More specific to our world, the negative health experiences that these patients report are not insignificant. 1/5 have been refused care because of their transgender or nonconforming status. 30% who have postponed care because of fear of actually going to a healthcare encounter. And also a roughly equal number of people who have delayed preventive healthcare or tried not to get preventive healthcare, especially when it regards, for example, breast cancer screening, prostate screening, et cetera, because of the sensitive issues that come along with phenotypic and gender. And so that is a challenge. It may not be immediately relevant to what we do as eye physicians, but it is important in the overall healthcare context. So what can we do? I mean, how can we be better? Really the primary thing is to be non-judgmental, to be open and to be professional. You want to really provide your care in a client-centered way. You have to meet them where they are. They may have had negative experiences and come to your office with a guard. They may not want to talk about their gender status or their nonconformity with you, but it may be relevant to what you need to do for them. And so you have to bring it up in a way that allows space for them to speak at their own pace. And this may take several visits to build that level of trust, and you have to be patient. You have to be an ally. So educating ourselves by attending meetings like this is important so that you are trans-friendly in your environment. You know the questions to ask and the ones not to ask, and you know how to open the door to have that type of conversation. The other thing is you have to be an ally in regards to seeing mistreatment of patients and saying something about it. Not necessarily in a punitive way, but in a way to educate our peers. Not all of us are always perfect. In fact, none of us are. And so we all will trip up and make mistakes, and we have to rise together. As far as things that we can do and enact in our own EMRs, we can change our patient intake forms to have open-ended questions about what pronouns people want and how they define their own gender, what's their preferred name versus their legal name. These are things that allow people space in which to express themselves instead of boxing them into an area where they don't feel comfortable. Flags in the EMR to point out which patients identify as trans, and things that you can ask. You don't have to ask it in a way. Some patients may feel uncomfortable if you ask this, especially if they happen not to identify as transgender. So you can preface your question by saying, this is something we ask of everyone. You normalize it. You make it part of your standard questionnaire so that no one feels that they're being singled out or judged based on their appearance, which might not necessarily match what you had expected. Creating a trans-friendly environment is different in each healthcare setting. In some places, it's particularly important to have gender-neutral bathrooms to actually represent trans people in materials. This may not be as easy to do with ophthalmic materials, but that's okay. Having a single occupancy restroom in a waiting room is actually enough sometimes just to avoid the discomfort of having to someone go and potentially be challenged about entering a certain door. There are publications that are known to be gay-friendly and trans-friendly, and to have those in the pile of magazines that you have in your office actually already opens the door for someone to feel more comfortable. There are small things that you can do to make a big difference. So I'll finish up with some really, really specific customer service things that we can do to help people out, and you really want to avoid gender-specific markers in terms of how you greet people. You don't have to greet someone by their gender. You can just say, how can I help you? Oh, I'm sorry. I've had an animation here, but it's not. May I just exit here for a second? Yeah. Okay. I'm just going to get rid of that. So I'm going to get rid of these. I'm so sorry. The animation seems to be not working for some reason.
Just go back in the slideshow.
Yeah, I will. There we go. So sorry about the busy slide. I was going to go through them one by one, but you really have to find a way to politely ask the uncomfortable questions, especially about pronouns. And so it's okay to ask these things. And in fact, patients will be glad that you did. But you don't want to alienate someone, and you don't want to seem uncomfortable when you ask that question. So practicing a statement like is listed here, I'd like to be respectful, how would you like to be addressed? I mean, that's a very reasonable thing to do. Names are the same. Legal name, preferred names are different. Everyone knows about nicknames. This becomes especially important in someone who's transitioning, because they may not want to be called by their legal name, and that could create a barrier for you to be able to get them to trust you. And so asking those questions is important. We're going to goof up. It's going to happen. You're going to misgender someone. You're going to use the wrong pronoun. It's gonna happen as you learn to deal with this issue. And you simply just apologize and move on. I'm sorry that I used the wrong pronoun. You know, I didn't mean to be disrespectful. How can I help you? You know, and that diffuses the situation. Gender-neutral language, the Oxford Dictionary actually now recognizes they as a singular pronoun. Some of us are grammatically very pure and feel uncomfortable with this, but in general, try to be as gender-neutral as you can. And the other thing is to really only limit your questions to what is pertinent to the visit. So if they're there because they have a metallic foreign body on their cornea, you don't necessarily need to ask about whether they have had gender transition surgery yet. So there are guidelines all over the place. One of my favorites is the Fenway Center in Boston. They have amazing videos as well as presentations, including videos of good versus bad interactions in offices. They tend to center on primary care, but it's certainly applicable to what we do and very useful. And I want to conclude with this statement from the WHO, which is that the highest attainable standard of health is a right for each and every one of us, and we each have to play our part in making sure that that's the case for all of our patients, even the most marginalized. Thank you.
Thank you, Dr. Briceño. Our final speaker is Dr. Edward Wilson, who is the Miles Professor of Ophthalmology at the Storm Eye Institute in at the Medical University of South Carolina. And he will be speaking to us today on patients with disabilities.
Thank you. It's a privilege for me to be included in this. It's a very important topic. I was asked to speak on communicating with patients who are adolescent or young adult with a disability. I'm a pediatric ophthalmologist. I do see a lot of patients with disabilities and even adults with disabilities. I bring some credibility because I have an adult son who's disabled and uses a wheelchair and has low vision. And so I can speak as a parent as well as a caregiver. And I can tell you that parents and patients will recognize whether you are a practice that's friendly to persons with disabilities or not. And you really want to learn how to be very comfortable and be categorized as welcoming to patients with disabilities. These are my financial disclosures. So I'm going to share some general tips for communicating effectively with persons who are disabled and introduce people-first language, which you may not have heard that term before, and to share some feedback from patients, from my patients with disabilities on how they think your communication should be improved. Now, people with disabilities, I like to refer to them as people with other abilities. They have as many varied interests as those of us in the room. They have a lot of abilities, a lot of things they can do well. It's 54 million Americans who have a disability. It's the largest, most inclusive and diverse minority group we have. So use people-first language. This is very important in the disability community. You don't want to define, the disability doesn't define the individual. it is a man who uses a wheelchair, not someone who is wheelchair bound. You don't want to talk about the Down syndrome child. You want to, it's a child with Down syndrome. And that seems like a small point, but it actually isn't once you get further into this. Also avoid some of these terms like afflicted with, confined to a wheelchair, poor vision, suffering from, or handicap. Handicap is a word that actually means cap in hand. It has an origin of those beggars on the street with their cap in their hand. It's not a term of endearment in this community. You speak about a person who is blind. Might also be a person who is a dancer, a person who is an artist, a person with a communication disorder, a person who has cerebral palsy. Now, here are a few things, and I have a whole list that wouldn't fit on the slide. Advice to you from them. Talk to me and ask before talking to my support person. How often have we made that mistake? You make a quick assessment when you come into the examination room. There's an individual who may be an adolescent or a young adult or older adult. They have a caregiver with them. And you don't want to make the mistake to immediately start talking to the caregiver. Now, it may be appropriate to talk to the caregiver, but you speak to the patient and ask the patient whether you should be communicating with them or with the caregiver. Take me seriously. I know what I like and what I don't like. Now, if your patient is like my son, he is much higher functioning receptively than he is expressively. So he can understand a lot more than he's able to express in the time that you give him to express it. These patients want to be taken seriously. They know what they like. They know what they don't like. You can ask them if the room's too crowded, if they would rather see you without all the medical students. And please tell me what is going to happen next. Short sentences. Ask them if they understand. Talk in more concrete language rather than in language that might be harder to understand. And don't make any assumptions just based on their appearance on what they can do and what they can't do. You really want to be comfortable with individuals with other abilities. I think one of the reasons that I see a lot of families and even adults who have disabilities is because I'm just comfortable with them. And they're incredibly interesting people, and even someone with a disability that's fairly profound, often they have ways they communicate. They have abilities that you should recognize, and even if you have to mostly talk with a caregiver, you just learn to be very relaxed with them. Do identify yourself before speaking to someone with a visual impairment. Don't lean or hang on to a person's wheelchair. So the assistive devices are part of that person's body, and respected as private property. Do treat adults as adults. You want to talk in a normal tone of voice, and then you can develop a communication plan and a strategy that's right for that individual. But initially, treat an adult as an adult. And you don't have to be sensitive with patients that are blind. You don't have to be sensitive with phrases like, see you later. General guidelines, talk to persons with disabilities in the same way you would talk to anyone else. And then you can start to adjust your strategy as needed. You don't need to shout to them, speak in a normal tone of voice. And I would always, regardless of how profound the disability is, I speak to the patient first before I speak to anybody else in the room. And if they're in a wheelchair, sit down quickly. Get at eye level with the patient. That was mentioned before. You don't want to be standing over the patient. You want to get down at their level very quickly. And ask the person with a disability if assistance is needed. Don't assume that they need to be rolled out of the room or that they need to be helped into the examination chair. Ask them first. It's amazing sometimes you are under the assumption that you're going to need to have an army here to help them into the wheelchair, and they jump right out of the wheelchair and into the examination chair. And don't pretend to understand. The patients tell me that, don't just nod and, if you can't understand my speech, just say, I can't understand you. Could you repeat yourself? That's okay. A lot of people are so embarrassed by that they hear the mumbled words and they just nod and they just sort of pretend, and the patient knows exactly when you're trying to fake it. Be patient and listen. These patients take more time. That you have to be prepared for that. Don't complete the patient's sentences. A lot of these folks take longer to get the words out, and they would like to at least have a little bit more time to get those words out. So be patient with them and don't try to finish the sentence and very quickly. Short questions that require brief answers or even a head nod. They need your undivided attention. You can ask them, it's okay to ask them, how best do you communicate? How do you want me to interact with this communication device if they're using a board or something? And then you can develop a strategy. It's really nice when you see these patients over and over again, because you can develop a strategy and you're very comfortable from the beginning on how you're going to emphasize their abilities and not their disabilities. And recognize that a lack of effective and appropriate communication in this community is a real barrier to the delivery of quality health care. If you look up studies that have surveyed patients with disabilities, they are very unhappy with their communication with the healthcare providers oftentimes. So in summary, persons with disabilities are the nation's largest and most diverse minority. Developing a strategy for communication will improve the delivery of health care for all of us, and use people-first language and learn to be comfortable with those individuals that have other abilities. Thank you.